to our grand rounds this morning. Anyone who has worked with me or went to my grand rounds on the management of aspiration for cesarean scar ectopic pregnancies already knows all about him. But for those who haven't, an abbreviated introduction to him is as follows. He has the highest pedigree you can imagine, the highest academic pedigree, from Harvard for med school to UCSF for residency, and an ultrasound fellowship. And then he, from my understanding, was one of our first family planning fellows in the country. And since then, he's published about 1 billion peer-reviewed publications and has mentored another billion physicians in their research, including both myself and Dr. Shaw, who's one of our current residents going into family planning next year. In addition to being one of our most knowledgeable and evidence-based physicians in the CFP community, he also happens to be, and I really mean this, one of the most humble and accessible. And unfortunately for him, I have texted and called him more times than I can count regarding clinical care. And each and every single time he has helped me, and his advice has never steered me wrong. And I am incredibly appreciative of that. But what I think is most impressive about Dr. Reeves is that despite the stigma that often accompanies later abortion care, both within the medical community and outside of it, he has now created a clinical practice that centers proud, data-driven, compassionate, high-quality, trauma-informed, all-trimester abortion care. Dr. Reeves, patients are so lucky to have you. We are so lucky to have you. And even though our world in reproductive rights and health right now is dark, you are always a source of light, and you are deeply appreciated. And with that, I welcome you. Thank you so much for sharing your time and expertise with us this morning.
Dr. Reeves, I believe you're still muted. Oh, no, actually, go ahead and speak. I think your microphone might be set to a different microphone.
Can you hear me with this microphone?
Yes, all clear.
Okay. Fortunately, that's not my AirPods, so I'll put those away. Well, maybe I'll keep them so I can hear if anybody has any questions. Well, thank you, Lily. That was a very kind introduction. And it's a pleasure to be here with you all today to talk about later abortion and how it's changed over the last few years. And well, I'll start with the usual disclosures. Sorry, there's no CME. I imagine that's because I started my own surgical instrument company. Don't do it. It's a pain, and you don't make any money, and you can't get CMEs for things like this. So I highly recommend not doing that. But it is kind of fun to make surgical instruments, and we'll come back to that a little bit later. I'm also on the board of DKT International, which is a nonprofit that most people know as the manufacturer of the iPass aspirators. And I do work with GenBioPro and mifepristone and misoprostol, which we'll talk about. Medicines 360 has nothing to do with this. So we're going to talk about later abortion protocols and discuss how they've changed over time, over the last decade or so, and describe what we call induction evacuation. It used to be called a hybrid method, and we'll go into some detail on that. We'll talk about lidocaine to induce fetal asystole, and we'll also touch on cabergoline for breast pain, because I think that's something important outside of abortion care. I wanted to start by acknowledging all the clinics I've worked with over the years, both in the US and abroad, because they've really contributed a lot to how things have changed over the past decade, 2 decades. And I want to start with something you're going to see throughout my slides, and this is, I guess, one of my small hills to die on. I'm just not a fan of gravidity and parity. Um, Gravidity, adding up an ectopic with a miscarriage, with a vaginal delivery and a C-section, just kind of the equivalent of adding up your surgeries, an appendectomy and a cholecystectomy and 2 knee surgeries or something. Just doesn't really make sense. Um, Parity was a great concept when there was no such thing as a C-section. Adding up a term delivery and a 24-week cesarean to get 2 really isn't particularly useful. If you have 3 vaginal deliveries versus 3 C-sections, so you're a pair of 3, your management in labor is going to be very different. So putting them together into one number is just not particularly helpful. And so it's not something we use at the clinic. We use V's and C's, so V3C0 instead of P3, because this makes it much clearer how we're going to manage a patient. It's actually less important in later abortion than it is on labor and delivery. So what is later abortion? It depends on who you're talking to. After 24 weeks is a common definition. This is often considered the typical viability line. Viability is a whole nother topic we can talk about if anybody wants to. Sometimes it's also defined as 3rd trimester, or 28 weeks or more. Sometimes it's also defined as 26 weeks, which is neither 3rd trimester nor viability, but it is commonly used. And why do we need later abortion? So there's a lot of reasons, and this is part of the reason laws are not great for healthcare. Is just like everything, like a hysterectomy or a C-section. There are a lot of reasons you might need to do a procedure, and defining those reasons can be problematic. I imagine most of you have encountered the common maternal health ones like PPROM, previa with bleeding, and the whole myriad of other conditions that are hard to put into a list. There's also fetal anomalies. There's structural anomalies. The most common ones that we see in the after 24 weeks are neuroanomalies and cardiac anomalies. The neuroanomalies tend to be progressive, so ventriculomegaly may worsen as the fetus develops in the 20 to 28 week range. Cardiac anomalies may not be well seen until after 20 weeks, and by the time they've gotten a fetal echo and the plan's been discussed, they're after 24 weeks. Genetic conditions tend to be moving earlier with better detection even in the 1st trimester, but certainly early in the 2nd trimester. But there still are cases when it's discovered later. Some of those are twins and may need selective reductions. But there are still other conditions that are detected later. Some are just rare conditions. We've seen one not too long ago that was a lethal genetic anomaly that was only reported about less than a dozen cases in the literature, and took specialized testing that took about 6 to 8 weeks to complete to diagnose the condition. And then what are commonly called social, but in many ways are political indications, and I call them political because they're largely due to the politics around education, sex education, and just other things that prevent access to earlier abortion. So for teens, this is largely the case where many of them aren't aware they're pregnant. They may not know how they become pregnant. We also see a good number of preteens. This tends to be a little different for preteens. It tends to be more sexual assault and less just not knowing how pregnancy happens. But similarly, they don't know what pregnancy looks like, feels like, and typically aren't discovered until an adult tells them that they're pregnant. And then there's the larger category of just unaware of pregnancy, which the teens and preteens fall into. But there's many other folks who become pregnant while using contraception and don't know they're pregnant. These can include luteal phase pregnancies with IUD insertions, particularly Mirena, because they're told they may get amenorrhea, so they do. They don't think about it until the pregnancy is apparent. There's also patients who are told they can't get pregnant. So they don't think they can get pregnant. They've been told they can't get pregnant, yet they are pregnant, and they don't realize it until they start showing. And then there's a whole category of folks who are delayed. You guys are lucky to be in a state with good access, but for much of the country now, they're unable to access abortion at a early stage in the pregnancy. They may be able to mail order medical abortion pills or something like that, but if they can't get access to that, they have to travel, and traveling is expensive. It takes time and takes coordination, and often delays things many weeks, and sometimes into the third trimester, depending on the situation. So for later abortion and for all abortion, really, we've divided the world into procedures and medication abortion, or procedural abortion and medication abortion are preferred terms now. And this is true later for abortion care as well. For procedures, these typically start with inducing fetal asystole. Both of them start with inducing fetal asystole. For procedures, there's some cervical prep, traditionally with osmotic dilators, and then an evacuation procedure. This tends to be shorter and faster. It's more involved for the physician providing the care. In the past, there were a lot of studies showing this was safer. These studies were basically all done before the age of mifepristone and misoprostol. It's unclear, I do procedures, so if anything, I'm biased towards procedures, but I'm not convinced that they're actually safer. I think both are quite safe. So now that we have induction with misoprostol and mifepristone, medical induction is very safe. Even without the mifepristone, it's quite safe. Mifepristone is really ideal. It's ideal pretty much for everybody. It makes everything faster and easier. So if you can get mifepristone and use it before any inductions, it speeds things. So it's good from like a hospital system point of view in terms of time in the hospital and time of induction. It's great for the patient because it goes faster. They're done sooner, and they need less misoprostol. And the more misoprostol, the more cramping, the more pain. And I put here lots of misoprostol. It often isn't lots. If you do mifepristone before, it can be 2 or 3 doses. But I guess the key point is that it's more than you'd use in a term induction. It is more involved for the patient. The patient's, uterus is doing most of the work, and they're feeling a lot of the pain, and it can drag out for several hours, or many hours in some cases. It does allow for an intact viewing, so some patients prefer this if they want to do a viewing afterwards. So this is the traditional plan for a later abortion procedure, more or less, well, depending on who's doing it, sometimes after 20 weeks, but definitely after 24 weeks. To start with an injection of digoxin, sorry for the typo there, intrafetal, and then waiting a day to make sure that works. So one of the key things for later abortion is that we are doing an abortion procedure, and we're not inducing preterm labor. So you want to start by inducing fetal asystole before you start preparing the cervix. Then on the second day, they would place osmotic dilators, sometimes just one, sometimes more. And on the third day, more dilators. And on the fourth day, a brief induction followed by an evacuation. There's really only so much dilation you can get with osmotic dilators. In the past, people have used what I'd consider kind of outrageous numbers, double-digit numbers. But generally, you don't need that many. And the easiest way to get substantial cervical dilation is with a brief induction. So how to shorten the process? So that was a 4-day process, 4 complete days, really. And from my time as the medical director of the National Abortion Federation, I got to see a lot of these procedures, and it occurred to me that we really could shorten this a lot. To start with, we could do an injection that causes fetal asystole immediately, and that would remove a whole day from the process. So if you knew you had fetal asystole during that first visit, you could go ahead and place dilators or do something else to prepare the cervix. And at least when I started, that was KCL. However, in talking to some folks, I learned and then read about lidocaine, and started using lidocaine actually when we opened the clinic. Previously, I'd used KCL. And I'll come back to lidocaine. It has some advantages. Then adding mifepristone to the whole process um, speeds everything. So it helps the cervix become ready to dilate, essentially by blocking progesterone. Um, you're letting the uterus know that it's time for the pregnancy to end, and it really does speed the process. And this has been studied before in many for medical abortion, and shown that the more time with mifepristone, up to 48 hours, the shorter the induction. And essentially, by giving mifepristone after the injection, you can get things started, place a set of dilators the next day, and then do the induction on the third day. Or if they're on the earlier side and have some vaginal deliveries, you can do this in 2 days, where you do the injection, give mifepristone, and place dilators, and then the procedure the next day. So by doing this, you can shorten the procedure from 4 days to 2 to 3 days. There are some things to consider before doing later abortion. One is that everyone needs to be prepared emotionally. This includes all the staff, of course, the physician who's performing it, but also the nurses, medical assistants, anyone who's going to be involved needs to be prepared. Attitude is everything is a quote from George Tiller, who was, well, he was murdered in 2009 in his church, but he developed that original 4-day protocol before mifepristone was incorporated. And really this is about treating the patient right and being there for the patient and their emotional needs and their support throughout the process. And that really is important. It's really important to have the patient's trust and to work with the patient. We've learned this over the years. The more trust you have with the patient, the better everything goes. It's amazing what we've learned that in the past we might never have learned. How many Percocets they're taking a day is one example, where in the past we might have just thought, wow, they needed a lot of narcotics. And now we know why, because they tell us. And it really helps improve patient care. And this is part of trauma-informed care, and it really is part of giving control back to the patients. And one of the main things and the most important things is to ask permission for everything we do. Anytime we touch the patient, we ask for permission first. I think for a lot of folks who haven't done this, it seems maybe makes them a little nervous. The patient is going to say no. Sometimes they do, but most of the time they don't. And it really helps put the ball back in their court. And so it makes it clear that they understand what's coming if they acknowledge that you're about to do an exam. So this is our protocol for D&Es up to 26 weeks, or through the 26 weeks. We start with, on day 1, an injection to induce fetal demise with intracardiac lidocaine. We give them mifepristone and we place osmotic dilators. We use a mix of dilapan and laminaria. We used to solely use dilapan, and I think overall prefer dilapan. But for reasons known only to the company, they've raised the price to exorbitant levels. So we mix dilapan and laminaria. Both work fine, and it doesn't really matter too much. It's more of a personal preference. On day 2, we give 400 of these vaginal misoprostol 1 hour prior to the procedure, and then we perform a traditional D&E evacuation. And this works well through 26 weeks. we use it for pretty much everybody through 24 weeks, and if they've had a vaginal delivery, we use it for 25 and 26 weeks. If they don't have a vaginal delivery for 25 or 26 weeks, or they're 27 weeks or later, we do a 3-day procedure. This is for the 25, 26 week group, where we're basically doing a D&E. So we basically stretch that prior protocol out to 3 days and move the dilator placement to day 2. So we start with the injection of mifepristone, then we do the dilators on the second day. We do basically the exact same procedure on the third day. This gives the mifepristone time to work, and works extremely well for our teens and preteens. So that's the other group where we might do this earlier, is if it's a teen or preteen. The mifepristone the day before really helps prepare that cervix so that instead of placing dilators in a tiny nulliparous young teen or preteen cervix, it often looks more like a cervix that is ready to be dilated. If the patient is at 27 weeks or later, we do what we call the induction evacuation. And so for this procedure, the first 2 days are the same. And then on the third day, we will remove the dilators, rupture membranes, and then do serial doses of misoprostol, 400 every 2 hours. We use 200 if there's a prior cesarean. And once the cervix is adequately dilated, we move back for an evacuation. In this case, the evacuation is really more of an extraction. It's typically intact. We decompress the calvarium, which we'll come back to, but allows a viewing for the patients. Yeah, I'll come back to the rest of that. So this is that protocol more or less in a table form. There are a few exceptions, and there's some subtlety. So if anybody wants to put this into practice, please reach out and I can explain some of the things we've learned over the years that make a difference. And most of that's related to when we give the mifepristone. In cases with a high number of vaginal deliveries, we'll delay the mifepristone because often it works a little too well, and if you want to wait till the third day, you may need to delay the mifepristone. So these are all instrumented procedures. So for the evacuation, dilation evacuation, the pregnancy is not intact. It's done with forceps like a traditional D&E. For the ones after 27 weeks, we do 95% as an extraction, where the calvarium's decompressed and we extract the fetus otherwise intact. And we can do this whether it's cephalic or breech. This is more detail on the whole process. I think I've covered this well enough. I want to leave time for some questions. Day one is a lot of talking. It's a lot about making sure the patient understands the process, that they're sure they want to go ahead, they understand the risks. The one thing about the ultrasound that is a little different about what we do is we measure the humerus length for everyone, because we do have a good number of neuroanomalies where the BPD and head circumference are not particularly useful. The abdominal circumference is, as you all know, is the worst predictor of gestational age, essential for fetal weight, but not great for gestational age. So we use the humerus length and femur length. We'll come back to the injection of mifepristone. So the first step for any later abortion is inducing fetal asystole. If you don't start with this, you can, and it has happened, you can induce a preterm birth, which is not the goal. It's probably the worst outcome. The last thing anybody wants is a preterm birth. It also makes sure that the patient's decision making is complete. We aren't trying to force the decision, but we are trying to bring the issue to a head. So if somebody doesn't want to go ahead, we don't want to start preparing the cervix and then discover that they were unsure. And so we make it very clear that this is the no going back point and that they need to be sure. And it does really bring the issue to a head. And we have had patients more than once stop, basically as we're cleaning the abdomen in preparation for the injection. And that's really the goal, is to make sure that if this is not what they want to do, that they let us know and we stop, and that we don't start preparing the cervix and then discover that they weren't sure. Um, Doing the injection reduces uterine blood flow. This hasn't been well documented in humans. It's very well documented in animal models, and largely it hasn't been documented because it basically haven't gotten around to it. But it is quite easy to see. It's just not, it hasn't been quantified. After we do the procedure, we document the asystole, and we have, as we should for a Doppler image, we have other flow elsewhere in the uterus in the same image that we're showing no flow within the fetal heart. We repeat that on the next day when we do dilators, and the blood flow in the uterus has decreased so dramatically that often we have to increase our depth and include the aorta or vena cava below the uterus to show that our Doppler is working properly. The inducing fetal asystole and having a fetal demise for 2 days really does seem to make the D&E easier. There's one study showing that it didn't, but they use intraamniotic digoxin the day prior, and intraamniotic digoxin doesn't work immediately. In fact, it often takes almost 24 hours to work. So it's probably not useful to extrapolate from that study. All the docs who've been doing this told me 2 days of demise makes it easier, and I have to say I agree with them, but it's not well studied. This is a list of the methods you can use. You can use digoxin. Intrafetal's much more effective and rapid than intraamniotic. You can use potassium chloride intracardiac, and you can use lidocaine. You can also do it transvaginally with digoxin, which works well. Lidocaine does not work well transvaginally. It's hard to get the right placement. And I'm going to leave it at that for this talk. This is just a chart of doses and efficacy. KCL and lidocaine are a little technically harder, which is limits access a little bit. The big advantage to me of lidocaine is that you can numb on your way in. So you can numb the rectus muscle if you're going laterally. I try to stay pretty close to midline and go through the linea alba when I can, but you can numb the rectus. You can also numb the myometrium. And as soon as you enter the fetus, I usually give 2 mLs, which is 20 milligrams, and is a near toxic dose just by itself, and numbs the fetus pretty quickly. It is a newer technique, but it's not as new as it used to be. This is a study we published a few years ago and found that it was quite effective. In this study, we defined success, which was 99.3% when it was intracardiac. Success was defined as asystole achieved before the patient left on day 1 without a second injection. So about 1 in 100 overall will need a second injection. In this case series, it's also important to note that this included new learners. So there were 3 of us. I had already been doing it a while, but one person had started a few months before this data collection period, and one started during. And despite that, we still had very good success. Intrathoracic was more effective than we expected. It is important to note that we were trying for intracardiac, so even when it failed, the intrathoracic was close, at least somewhere central in the thorax. So it may not be generalizable to anywhere in the thorax. So mifepristone. We have standardized our methods now to give mifepristone at 8 p.m. on day one after the injection for most patients, and then 9 a.m. on day two if they have one or more vaginal deliveries. Typically, the number of C-sections does not affect when we give the mifepristone. This is our protocol for dilator placement. It's not that different, I think, from what anyone would do. The one important thing is if we've given mifepristone, if this is on day two, not right after the injection, we always do a cervical exam. It's quite common to discover that the cervix is 2 centimeters or more, in which case we don't place dilators. We do a paracervical block with bupivacaine, which is less for the dilators and more for the pain afterwards. It typically lasts somewhere in the 2 to 4 hour range, and helps with the pain. Another important thing is that the mifepristone the day before helps with the pain, because the cervix is ready to dilate. So there's less of a battle between the osmotic dilators of the cervix and more of the cervix just going along with what the dilators want to do. So it really does seem to decrease pain as well. We give them meloxicam and tramadol for pain afterwards. Most patients don't need much of any of the tramadol. Meloxicam is nice, and we switched to that because the pills are tiny, and a lot of our patients have trouble swallowing. It lasts longer. You do need to be careful to tell them not to take too much because you don't need more than 2 pills a day. In fact, 1 pill a day is recommended, but definitely not more than 2. We also give them gabapentin that night, and gabapentin, as I'm sure you guys know, in your ARIS protocols in the OR, pretty much everybody's getting gabapentin before their surgeries these days. We discovered that when we give it on the morning of the procedure, because it takes a while to kick in, often not reaching peak effect till 4 hours, that patients were falling asleep after their procedures from the gabapentin. So we give it the night before, helps them sleep, and has lowered our fentanyl need tremendously. Over time, we've discovered we need fewer and fewer dilators, and we kind of stabilized after 2003, but typically most of our patients are getting about 5 dilators now. We used to, before 2022, almost everybody got 7 to 10, and we've slowly gone down, discovering that we really don't need the dilator effect any more than we just need them to be there and make sure we can rupture membranes. The cervix is soft and stretches, and that the number of dilators is not really that important. And just to add to that, what seems to be more important and what's been shown in prior studies, the dilators are largely, there are 2 potential effects. One is they're swelling and forcing the cervix open. The other is that they're irritating the cervix, inducing local prostaglandins and causing dilation. And that latter one seems to be more important, and really has a profound effect. We regularly have 5 dilators, and the patient will be 4 to 5 centimeters when they come in, which you really can't explain by those five dilators, which together are barely 2 centimeters in diameter. So for our induction, we have all our patients use 400 micrograms vaginally 1 hour before the appointment. We use moderate sedation in the procedure room, so a mix of fentanyl, Versed, low-dose ketamine, and dexmedetomidine, or Precedex. We remove the dilators, we rupture membranes, and we do a paracervical block of bupivacaine and hydromorphone. This is I guess, an old technique. It was used in labor on labor and deliveries prior to electronic fetal heart monitoring. And it works great. There's a lot of published randomized trials showing that it's very effective for labor pain. But as soon as there was electronic fetal heart monitoring, they discovered that it causes profound decelerations, and it pretty much died a sudden death, and has not been revived. There is a nice summary of all this data and up to date. We place it with an Iowa trumpet, or another device we made that protects the needle a little better. And So we don't do a speculum exam, but we put it around the cervix from 379, 3579 o'clock on the cervix. And then we place misoprostol within the cervix, actually kind of in the lower uterine segment, after the amniotic fluid is drained. And this is something that Warren Hearn at Boulder started doing about 40 years ago, and it works very well. And then we continue the misoprostol every 2 hours, buccal or vaginal, until the cervix is ready. Typically, it's just these first doses, maybe one more buccal. We typically do the 4 hour after RUM meso vaginally because we do an exam because often the cervix is dilated. We have doulas for all our patients. They provide support and work with the patient throughout the process. So we try to have the same doula throughout a patient's stay, so they meet the patient on the first day, get to know them better on the second day, and can really bond with the patient and be there throughout the third day. And this is really one of the things that's made the process very successful. And as I mentioned before, allows us to learn more about the patient and provide better care for them. And I guess it's worth saying our doulas are on staff, so they're not volunteer doulas. We have a team of 8 doulas at the clinic. We do a lot of multimodal pain management. The doulas and their emotional support is a key part of that. Sometimes we use TENS units. We also combine some maybe atypical pharmacologic agents. Gabapentin's hugely helpful. Basically halves our fentanyl need. We use caffeine on the day of the procedure, both to augment other pain medications and, well, also partly to prevent caffeine withdrawal, because we had a good bit of that for patients skipping their coffee in the morning, and we don't want any caffeine withdrawal. And we add Tylenol to everyone. I was a bit resistant to this. Most ORs are doing this for everybody, and I had some anesthesiologists convince me that there was no harm. So we do that. It is nice. It also may reduce our fever incidence with the misoprostol a little bit, but it seems to do no harm. In the procedure room, we have the doula there with them. We have our own ARS protocol for this procedure. And as I mentioned, we use a mix of moderate sedation drugs through this. This is a graph of our induction times. And this is limited to patients who got mifepristone 36 to 42 hours before their procedure to make it more comparable between the number of vaginal deliveries. And you can see if they have 2 or 3 or more vaginal deliveries, it's quite quick. And this is why we actually don't give the patients with vaginal deliveries the misoprostol 36 to 42 hours, because some of them are a little too quick. And we will actually shorten that misoprostol time to make them follow the same curve. But you can see by 6 hours, in all groups, more than 80% of patients are done. This is our median induction time by gestational age and by vaginal deliveries. And essentially, we adjust the mifepristone to make the median induction time more similar between the groups with the number of vaginal deliveries. And in a regression that we presented this last year, we're writing it up now, we basically found that mifepristone, every 6 hours of mifepristone shortened our induction time by about 25 minutes. And every vaginal delivery also shortened our induction time by about 20 minutes. So by delaying our mifepristone, we can balance the vaginal deliveries in the mifepristone. The induction is a little longer by gestational age. C-sections were not significantly different. It's not surprising that they are. That we're more gentle and we do a substantially lower dose with prior cesareans. For the last step, we typically move back to the procedure room when the patient's 5 centimeters or more. The thing we've discovered quickly is that there's a much steeper labor curve. labor curve from 5 to complete tends to be closer to a centimeter every 2 to 3 minutes than every hour. And often by the time we walk a patient from their patient room to the procedure room, they're complete. So that's, with positioning and everything, 10 to 15 minutes. We do a second paracervical block for the procedure with a lower dose of lidocaine, since we have given bupivacaine earlier. We also have vasopressin and ketorolac in that block. And then we do the extraction with the DuPont cannula decompressing the calvarium. And then we use a double-tooth tenaculum for an assisted delivery, very similar to the way you do a forceps delivery. We remove the placenta, and then we do a gentle aspiration to remove any fragments. Whether or not this is needed is something we've discussed. The main difference between this and a normal delivery is that many of our patients, about 3/4, are getting on a plane or spending most of the day in a car the next day, and we don't want them passing anything while they're traveling. So it does seem worthwhile. We get probably a little more than you might expect after the placenta is removed, even when it looks intact. Afterwards, we give oxytocin, and we also give cabergoline. And I'll come back to that. This is the DuPont cannula that we use to decompress the calvarium. Traditionally, head decompression was done with a combination of scissors, typically Mayo scissors, that would puncture the calvarium and be spread, and then a regular cannula of any type really was placed intracranial and suction applied. This allows us to do it in a little more controlled fashion because we can see, we place the cannula inside the sheath, pulled back, and we place the sheath, and we can see it on ultrasound or direct visualization, depending on the case, and then advance the cannula, puncture the calvarium, apply suction, and decompress the head. So this has really changed things. This is something we developed when we first opened the clinic and has really changed our ability to achieve head decompression easily and quickly and safely. Lastly, I want to touch on cabergoline. This is a study that we performed a few years ago, just published last year, of cabergoline for breast pain. So cabergoline has been known for years. There's several randomized trials of cabergoline at term to prevent breast pain and lactation for patients with fetal demise. We started using it pretty much in the year we opened, or year after we opened in 2017. And it has been a dramatic change. The one thing there was not data on is the second trimester. So this was a study of cabergoline for second trimester abortion. And the reason this was of particular interest is that it wasn't clear that the side effects outweighed the benefits. And so I really wanted to know that that was the case. So before we were using cabergoline, by far the #1 complaint when we called our patients a week after was breast pain. Far and away, it was like everybody complained about it. When we started using cabergoline, everybody started complaining about other things, and it wasn't clear whether we had removed the #1 complaint and they just found the #2 thing, and they reported the #2 complaint to us instead of the #1. And I wanted to make sure that was the case, that we weren't causing more leg swelling and foot edema and other problems. So it turns out that was the case. In this randomized trial, the breast pain and complaints were just dramatically lower, but there was absolutely no difference in the other side effects. And if anything, it was worse in the placebo. So that was very reassuring, and reassuring enough that even though this was 18 to 28 weeks, we actually started at 14 weeks because we still get a decent number of complaints there. And if there's no difference in side effects, then there's really no harm. It really is a great agent, and I encourage you to use it for anyone who has a fetal demise. or an abortion, because it really does make a huge difference. We actually, in the middle, not part of the study, had our own little randomized trial, or not randomized, pseudo-randomized trial, where we had a shortage of cabergoline due to COVID, and discovered that half a milligram, because we rationed it, we used half the dose, does not work. You need the full milligram to have the effect. One of the big differences for us in a clinic compared to in a hospital is what's safe in a clinic. For us, these are our the main criteria, let's say. We go up to, but not past 33 weeks at the first appointment, and not past 30 weeks of a prior cesarean. It turns out that after 30 weeks, there is a increased risk of uterine rupture. We screen everyone for preeclampsia. Once you get past 30 weeks, as you might expect, the risk of preeclampsia goes up, even past 26 weeks. We do see patients with substance use. The main thing that we want to know is what the substances are and when they're using them, and generally we can make it work. The one thing we can't deal with is withdrawal. It's an outpatient procedure, and we can't provide the sort of support and monitoring needed for withdrawal. So we have sent several patients over to GW's, the hospital closest to us, a few blocks away, where we have privileges, and we take them to GW if they're in acute withdrawal. These are our transfer rates. For patients without a cesarean section, the transfer rate is extremely low. Most of these tend to be kind of oddball things, allergic reactions, other things that happen in life. For prior cesareans, it does tend to be bleeding. And it's about 1.5% to 2%, so not a lot, but some. And we don't see patients after 30 weeks. All right. So in summary, using these protocols, later abortion is not technically difficult. It's combining multiple modalities or multiple agents to prepare the cervix makes it pretty straightforward. It is important to remember that fetal asystole is the essential first step. Mifepristone has really changed how we do these and how simple it is and how quickly we can do these. Cabergoline has really changed our post-procedure experience for our patients. The hardest part of all this is the patient experience. This is a hard thing for patients to go through. For us, about 3/4 to 80% of patients are traveling out of state, sometimes for the first time, sometimes alone, for something that feels very scary. So supporting them through this is one of the hardest parts of the procedure. So thank you all, and I'm glad to take questions. Fortunately, I can't see the time, so hopefully I didn't go too long here.
Thank you so much, Dr. Reeves. Does anyone have any questions? Go ahead, Dr. Matthews.
Hi, Dr. Reeves. Thank you for a great presentation. I'm one of the complex family planning doctors here. And I guess my question is, we've been doing 2-day laminaria induction. So our gestational age limit here is 26 weeks and 6 days. And so for D&Es, anyone above 24 weeks, we've been doing 2 days laminarias. Do you think it would be added benefit to doing the 2-day of mifepristone versus the 2-day of laminaria? And is that something that you guys have looked at? And what's your thought? I know there's mixed feelings and reviews about this.
Yeah, I mean, I guess I should start with my personal bias. I've never liked two sets of dilators. I was made to do it briefly as a fellow, and I didn't like it. So that's my bias. And I think by giving mifepristone on day one, you can essentially achieve what you need so that on day two you can place as many dilators as you want. And that chart I showed of the number of dilators we use, that's not because we can't fit more, it's just because we stop. I mean, the day after mifepristone, we could fit, 10 to 12 to 15 if we wanted, maybe more. Um, but we don't need to. And I think that's, um, yeah, that you really can get away without doing two sets. And I think you'll find your patients love it. I think forgot to say that now about 25% of our patients, we don't even place dilators on day 2. We do an exam and they're 2 centimeters or more, so we don't place any dilators, and they do great. You do need to be a little more, well, I'm not gonna say, maybe you're very gentle. I hope you're very gentle already, but you do need to be a little gentle with the D&E because you don't want to cause a cervical laceration because the cervix is softer. But it tends to stretch. So as long as you provide kind of gentle force, the cervix will stretch, and it goes quite well. So I think the addition of mifepristone really can help you reduce one of those dilator sets, which patients love not getting dilators, and it's also nice for you to skip one dilator set.
See, Dr. Bayat's hand is up.
I was gonna see if others had stuff to say, so I wouldn't hog all the time, but thank you, Dr. Reeves. I think one of my biggest challenges is a lot of the data that we have is based on outpatient practices. And I think that's always harder for us in the hospital to adapt.
Mm-hmm.
And I think Dr. Matthews was talking a little bit about that. So, things like doing timed amniotomy, things like that, when we don't have flexibility with our OR schedule is always
Yes,
hard.
yes.
So I think that, again, another one of the reasons why it's so important to have ongoing collaborations with outpatient and inpatient models of care is to figure out how to make what we're doing in the hospital with less flexibility better. But I think my heart is really heavy when I think about the patients who are too medically complex to be taken care of at an outpatient center who
Mm-hmm.
need later abortions. And I'm wondering what your thoughts are on how we can build relationships in states where there are no gestational age limits. For example, New Jersey, where you practice, about how we can destigmatize later abortion care and be able to extend it into the hospital setting so that patients who need hospital-based care because of their medical complexities can get what they still need to get. And if you have experience with that with your local hospitals or how that process has gone for you.
Yeah, it's a great point. And before we had the clinic, I did start with doing these outpatient and then taking them to the hospital, and it was a real problem, right? If you give mifepristone, an hour before, but they, they put it in on their way to the hospital, even supposedly 30 minutes before or so, and then the OR is delayed. It can be 3 or 4 hours, or maybe even 5 or 6 hours. And that creates problems. That's one of the reasons I really wanted to be in a setting where we could control the process ourselves. So in the OR, it is quite problematic that way. Um, there, and we are fortunate in DC to have a great relationship with GW. The whole system's been very supportive. So we sometimes, well, we work with the whole faculty on labor and delivery for our patients that need to go there. And we've also worked a good bit with other hospitals. So where we start the process and then have them finish the induction at the hospital where their referring doc is. Um, and that has worked very well. It allows patients to go back to a place they know and be closer to family. And many of these are, well, not some, some of them just want to go back to where they came from, but some are also complicated and need hospital level care that we can't provide. One that is maybe an extreme case that comes to mind is a patient on with a kidney transplant that was failing on dialysis and it was due to severe poorly controlled diabetes. That's not something we can manage in the clinic and needs hospital level care. So having that option is really important. Um, if your labor and delivery is supportive, this is something that can generally be managed on labor and delivery. And can be a good experience combining an outpatient start with completing the procedure inpatient. Um, and this is something that has been done really across the country. It's really, the laws have changed things a lot. We used to work with patients with hospitals, MFMs throughout the South to do injections and have them returned for inductions. Most places aren't comfortable with that anymore, and it's quite understandable. Um, but in the Northeast, we still do it a decent amount. It is also worth mentioning that Oregon Health Sciences has a great program for later abortion. There's no gestational age limit in Oregon, and they're doing a good number of procedures. Um, I can't speak to exactly how they do it, where they start patients, and how they manage it, but they are doing a lot.
And do you think anything has been most helpful in figuring out how to have that institutional support or buy-in? What your experience has been?
Um, uh, I don't know, I feel partly it's been luck with GW. And we also have Washington Hospital Center here. And then we've worked well with both of them. Um, and the reason I say luck is I worked once with the hospital where I trained, and it didn't go so well. Everyone was not so comfortable with that process. And so and I thought I was sure that would be the most comfortable place, right? I mean, it's well known for a D&E program that regularly goes to 24 weeks and sometimes beyond, and I didn't think it would be quite the issue. I thought I had everything set up, and it was. It made me extra appreciative of GW. Um, I think for us in GW, part of it has been that um, we do work closely with them. One of my docs is half time at the clinic. Well, now a little more than half time at the clinic, a little less half time at GW. But for her first 4 years, she was split half and half. And so everybody knew her at the hospital, everybody knew her at the clinic, and it just made the um, uh, kind of the relationship seamless. Um, and we have a good number of the residents from GW come and work with us. So they know us, we know them, and that's really helped. But the one of the bigger issues is not the medical staff; it's everyone else, particularly the nursing staff on labor and delivery, that they really need to be supportive. And if you don't have a supportive nursing staff, it can really um, lead to more problems. And that's what I experienced when I was working with uh, the hospital in San Francisco. So I guess I'd just leave it with, you need to make sure the nursing team has bought into the whole process and is supportive.
I have one last question. Before you created your DuPont specialized calvarium decompressor,
Yeah.
what was your Dr. Bite has been talking about your device so much. I'm like
Yeah,
trying to
yeah, and
get
I'm
it
glad to
here.
share if you want some, share some with you.
Yeah, I would
Because
like to try it out because my technique right now is to use the scissors and a suction cannula. So I would really appreciate trying that out to get the buy-in so that we can order some of that device here and make it easier and more efficient, for all of our team.
yeah, it just makes it easier, and particularly if it's breech, it can be a little tricky to do the scissors and then find the same spot and all that. Whereas this is all in one, and you can also see where you are on ultrasound easily and not have that changeover where you've lost where you were on ultrasound, and then so it does make it simpler. Um, and that was something that, and you could, I mean, I'm happy to donate some, but you can buy them from Medgyne as well. I think they still have some. They made it for me originally, and um, it is just it just makes everything simpler, I guess. It's the short answer.
And I think in particular for learning institutions too, it feels a little bit safer and more controlled too to have our learners
Yeah, it is more controlled. I wouldn't say, and it is safe, but you do need to be careful with it.
Yeah.
It's a large pointy thing. So you have to be careful and make sure you can see it and know where it is before you advance it, for sure.
All
Does
right,
anybody
so
else
Yeah.
have any questions? Any non-family planning folks? Anyone?
well, thank you so much. We are getting close to 9 o'clock either way. So I just wanted
Yeah.
to say thank you so much for such an informative talk and just wish everyone a great and successful day.
Thank you all, and happy Valentine's Day for everyone.
Thank
Thank
you,
you.
Happy
Dr. Reeves.
Valentine's Day.
Bye bye. Thank you.
Thank you.